Good morning. Myself, Dr. Terence Abraham, Reader, Department of Orthodontics in Royal Dental College. Today, I am going to take class on classification of malocclusion. So, before starting with the classification of malocclusion, what is malocclusion? Any deviation from the normal occlusion is known as malocclusion. So, coming to the next slide. So, as I told before, malocclusion is the any deviation from the normal occlusion. What is classification? Why we are doing classification? Classification is just grouping of clinical cases which has a similar appearance for easy handling and discussion. What are the advantages of classification? So, classifying malocclusion. Sorry, what are the advantages of classifying malocclusion? It helps in diagnosis and treatment planning. It helps in visualizing and understanding the problems. It helps in communicating the problem, and it also helps to compare the various malocclusions. Understood? So coming to the various classification of malocclusion. Malocclusion is broadly classified into dental, skeletal, and both. That is combination of both skeletal and dental. In dental, they again divided into intra-arch malocclusion and inter-arch malocclusion, as well as inter-arch malocclusion. Intra-arch malocclusion, that means malocclusion or it is affecting the group of teeth within the same arch. It is intra-arch malocclusion. In its term only, it is very clear. In inter-arch malocclusion, it is the malocclusion which is present between the both arches. That is, affecting tooth will be or affecting arch will be between the both arches. What is skeletal malocclusion? Skeletal malocclusion means malocclusion which involves various bones, that is mainly maxilla and mandible, according to our case. So in this flowchart, we can easily memorize the various classification of malocclusion: skeletal, dental, and both. In skeletal, it classified into three planes, that is anterior posterior or sagittal plane, vertical plane, and transverse plane. In sagittal plane, it may be anterior posterior direction, that is either retrognathic or prognathic or both. In vertical, it may be deep bite or open bite. In transverse plane, it may be cross bite, that is, or scissor bite. Coming to the dental, as I told before, classified into intra-arch and inter-arch. Intra-arch means within the same arch. So malocclusion affecting a group of tooth which is in the same arch. It may be spacing or crowding. It may be inclinations, displacements of tooth, abnormal eruption, rotations, or transpositions. That is exchange of the position of the tooth. Then inter-arch is divided into three planes: sagittal plane, vertical plane, and transverse plane. Sagittal plane, that is anterior posterior plane, may be class 1 or class 2 or class 3 malocclusions. In vertical plane, as I told before, in skeletal, it is deep bite or maybe open bite. In transverse plane, it may be cross bite or it may be scissor bite, that is buccal non-occlusion or lingual non-occlusion. So coming to the various intra-arch malocclusion which are presenting in the group of teeth which are present in the same arch. So mainly it is tipping and displacement. What is tipping? Tipping is the movement of the crown in one direction and the root moves in the opposite direction. It may be distal, mesial, lingual, or buccal, which is very clear from this picture because crown moves in one side and root moves in the opposite side. So in this figure also you can see tipping up, and the down figure you can see displacement. That means entire crown and both crown and root, that is entire tooth is displaced. That is also known as bodily movement of the tooth. So this is also you can see bodily movement of the tooth, and the down you can see the rotation, that is movement of the tooth along its long axis, that is rotation. And the down right figure you can see the canine is erupted in the lateral incisor position, that is exchange of position of two teeth, that is called transposition. Displacement, as I told before, it is the bodily movement, that is both crown and root moves in the same direction. Occlusion. There are two types of occlusion, infraocclusion or supraocclusion. Infraocclusion means the tooth is partially erupted. Supraocclusion means the tooth is erupted, supra-erupted. That is, these both are in the out of the arch. This infraocclusion, supraocclusion, this malocclusion is in the vertical plane. What is rotation? It is the movement of the tooth along its long axis, transposition, spacing, crowding, all I have mentioned before. So this figure also you can see all these figures. First figure you can see buccal placed canine. That is the displacement of the canine. And in the right top figure you can see crossbite. And next figure you can see midline diastema. And there is a anterior single tooth crossbite, lingual inclination of the upper incisor, deep bite. You can see rotations, and you can see the increased overjet, that is also known as anterior posterior malrelation. Coming to inter-arch malocclusion, that is abnormal relationship between the teeth of one arch to the other arch, that is malocclusion present between the both arches. It occurs in the three plane as I told before: sagittal plane, vertical plane, and transverse plane. Sagittal plane, it may be class 2 or class 3. Class 2 means lower arch is distally placed. Class 3 means lower arch is more mesially or forwardly placed. Vertical plane, we already know it is deep bite and open bite. Transverse plane, that is cross bite and scissor bite. So in this figure, first A figure is normal relation, normal transverse relation of upper and lower arch. In figure B, you can see there is a cross bite seen in the right side, unilateral cross bite. Both. And figure C, you can see bilateral cross bite. Figure D, it is buccal non-occlusion, also known as scissor bite. And the figure E is a cross bite, complete cross bite, that is lingual non-occlusion. This figure G shows complete deep bite, commonly seen in the case of class 2 D2 cases. This is right figure which shows the buccal non-occlusion scissor bite. Figure H shows the open bite. These open bite and deep bite are in the vertical plane. Coming to the skeletal malocclusion, that is abnormality between the maxilla or mandible. It may be either maxilla or mandible or both. The defects may be in the size, difference in the size, or defect in the position, or it may be the relationship between the maxilla and mandible. It occurs in the three planes of space: in sagittal plane, prognathism and retrognathism; transverse plane, the constricted jaw, or it's the crossbite; vertical plane, it may be the variation in the lower facial height, that is skeletal deep bite or skeletal open bite, which results in the variation in the lower facial height. So in the first figure, the left side figure, you can see first is the normal relation, vertical relation of maxilla and mandible, and the middle figure you can see the clockwise rotation of maxilla and anti-clockwise rotation of mandible, which results in the skeletal deep bite. Down figure you can see rotations of maxilla and mandible in opposite direction, which results in the skeletal open bite. And the right side figure A, B, C, all these shows the anterior posterior sagittal relation of the skeletal maxilla and mandible. Coming to the angle system of classification, Angle is the first who classified the malocclusion into mainly three types. So he introduced the classification in 1899, but his classification was based on mesiodistal relation of the teeth, dental arches, and the jaws. According to Angle, maxillary first permanent molar is the key to occlusion. The main basic key or basic unit of the classification of malocclusion by Angle was the first permanent molar. He considered it as a fixed anatomical point. So based on the relation of the lower first permanent molar to the upper first permanent molar, he classified malocclusion into three types: class 1, 2, and class 3. So in this figure, you can see the A is the class 1, B is class 2 D1, C is class 2 D2, and D is class 3. So I will come to this figure later. So first coming to the class 1 malocclusion. So class 1 malocclusion, in this first figure you can see, when we focus on the first permanent molar, both upper and lower, you can see the mesiobuccal cusp tip of the maxillary first permanent molar occurs in the buccal groove of the mandibular first permanent molar. That is the class 1 molar relation, which is considered to be the normal relation. Then coming to the class 2 malocclusion. Class 2, in the figure B, you can see the relation between the maxillary first permanent molar and mandibular first permanent molar. You can see the distobuccal cusp of the maxillary first permanent molar occludes in the buccal groove of the mandibular first permanent molar. It is class 2 molar relation. He divided class 2 molar relation into two types, class 2 D1 and class 2 D2. In figure B, which is class 2 D1, that means class 2 molar relation with severely proclined maxillary upper anteriors. And class 2 D2, that is figure C, you can see the retroclined upper central and overlapped laterals over the centrals. So before coming to the class 2, then class 1, there is another classification which is called bimax dentoalveolar protrusion. That means class 1 molar relation as well as class 1 skeletal base, but there will be a malocclusion because of the proclined upper and lower anteriors. So the main features of bimax dentoalveolar protrusion was there will be lip incompetency, there will be lip strain, patient will have a convex profile, and severe proclined upper and lower anteriors. So coming to the features of class 2 D1. So class 2 D1, you can see extraoral features as well as intraoral features. In extraoral features, you see in this figure, see, when you see in this first figure, the figure of that boy, this is the class 2 D1, typical class 2 D1 case. Extraorally, you can see he has a convex profile, deep mandibular sulcus, incompetent lips. Then when you see in the intraorally, you can see there is a proclined upper anteriors, increased overjet, increased deep bite, then class 2 molar relation, and there is a constricted maxillary arch because of the lower position of the tongue. And because of lower position of the tongue, there is an unrestrained buccinator activity, which results in the constriction of the maxillary arch. As strongly you can see, as I mentioned before, deep mandibular sulcus, incompetent lips, and there will be increased lower anterior facial height. So strongly, there is increased long face, lateroprosophic face, increased lower anterior facial height, upper lip is hypotonic, everted lips, then there will be a hyperactive mentalis, that is lip trap. This patient, because of the increased overjet, there is a high chance of lip trap under the maxillary anteriors, that is, which results in hyperactive mentalis muscles. Intraoral features, as I mentioned before, class 2 molar canine, proclined upper anterior, deep bite, constricted maxillary arch, V-shaped arch, deep palate, and there will be a deep carosity. This is the figure of buccinator mechanism. Because of the lower position of the tongue, there will be a accentuated action of the buccinator muscle, results in constriction of the maxillary arch. Coming to the class 2 D2. In the class 2 D2, the down figure, the figure of that lady or girl, you can see the class 2 D2. That means a slight mild convex or almost straight profile. There will be a competent lips. Lips are competent. There is no much muscular abnormalities. So mild square face, uriprosophic face, competent lips, facial height is normal. Intraorally, you can see class 2 molar and class 2 canine relation. Upper, as I told before, upper centrals are procline and there is a crowding and overlapping of laterals over the centrals. There is deep bite, overjet is decreased, nervosity is present, upper arch is broad and U-shaped. These are the various intraoral features of the class 2 DV2. What are the types of the class 2 DV2? There are mainly three types of class 2 DV2: type 1, type A, type B, and type C. Type A means the incisors are retroclined and there is no crowding present. Type B means maxillary centrals are retroclined but laterals are labially tipped and overlapping. And type B is commonly seen. Type C, all the four maxillary incisors are retroclined and there is a crowding present in the anterior because of the overlapping canine. So coming to the class 2 subdivision. Class 2 subdivision means if there is class 2 molar relation at one side and class 1 molar relation on another side. That relation is known, that malocclusion is known as class 2 subdivision malocclusion. What are the difference between class 2 D1 and class 2 D2? In class 2 D1, you can see there is a convex profile, but class 2 D2 profile is almost straight. Class 2 D1, there is patient has long face, and class 2 D2 patient has square face, uricoscopic. Class 2 D1 lips are hypotonic, everted, hyperactive mentalis. There is presence of lip trap and there is a deep endolegal sulcus. But in class 2 D2, all these muscular features are normal. There is no abnormality in the muscles or in soft tissue. In class 2 D1, there is increased anterior and ill face like hyperactive mentalis, deep palate, T-shaped constricted arch. There is increased overjet, increased deep bite. There is normal angulation of the crown and root in the upper anteriors, normal path of closure and normal clearance. But in class 2 D2, facial height is almost normal. There is no muscular abnormalities. Arch is U-shape or square shape. Overjet is decreased because of backward path of closure. There is a closed bite, complete deep bite. There is an angulation between crown and root of the upper centrals, which is called column angle. Column angle. As I told before, there is backward path of closure due to the retroclined upper central incisors, and there is an increased curvature. As a result, there is an increased interocclusal clearance or freeway space. Coming to class 3 malocclusion. Class 3 malocclusion, that means the mesiobuccal cusp of the maxillary first molar. So in this figure, you can see, let me see whether, yeah, class 3. In class 3, when you focus on the first permanent molar, both upper and lower arch, you can see mesiobuccal cusp of the maxillary first permanent molar occludes in the interdental space between the mandibular first and second molar. This is class 3 molar relation. Class 3 malocclusion or class 3 malocclusion is divided into mainly two types: true true class 2 class sorry true class 3 and pseudo class 3. Coming to the class 3 malocclusion, there are true class 3 and pseudo class 3. True class 3, that is the skeletal class 3 of genetic origin. So the main etiology of the true class 3 or skeletal class 3, there will be a prognathic mandible or retrognathic or backwardly placed maxilla, hypoplastic maxilla. The main features of class 3 malocclusions are there will be a concave profile, lingually or upright lower incisors, reverse overjet or edge to edge, and there will be a lower position of the tongue. As a result, upper arch is constricted because of disturbed buccinator mechanism. Coming to the pseudo class 3, that means when we ask the patient to bite, he deviates the bite and he brings the mandible forward. He also known as habitual class 3. In the case of rest position or in the physiological rest position, jaws, both upper and lower jaws are in normal class 1 relation. But when we ask the patient to close, we glide the mandible anteriorly in the class 3 relation. The main reason for pseudo class 3 is there will be an occlusal prematurities. Because of the occlusal prematurities, there will be a gliding of the mandible, or there will be a deviation in the path of closure, or there may be a early loss or premature loss of posteriors, deciduous posteriors, or enlarged adenoids. These are the main reason for the pseudo class 3. In pseudo class 3, you can't find any true class 3 findings or clinical features. What is class 3 subdivision? Class 3 subdivision means there will be a class 3 molar relation on one side and class 1 molar relation on the other side. When we compare the class 3, true class 3 and pseudo class 3, in true class 3, you can see concave profile. There won't be any premature contacts. There is only a forward path of closure, increased gonial angle. The patient can't protrude, or patient can't bring the mandible backward because it is skeletal origin. Lower incisors are either retroclined or upright, and the true class 3 is usually corrected during growing period by orthopedic appliance, or after growing period we have to go for orthodontic surgery. But in the case of pseudo class 3, patient has normal profile or straight profile. There will be a premature contacts, and there is a deviated path of closure because of a habitual class 3 or habitual closure. Corneal angle is normal. Patient can retrude the mandible when we do the exercise. There will be a proclination of lower incisors, and the main treatment for pseudo class 3 is the elimination of early premature contacts. By we can do orthodontic treatment for correction of these premature contacts. And if we untreat this pseudo class 3, it may lead to true class 3 in future. So this is the diagram of a or case report of a ankles class 1 with bimax, that is bimaxillary dentoalveolar protrusion. Here you can see patient has convex profile, incompetent lips, and intraorally you can see class 1 molar relation, class 1 malocclusion, class 1 skeletal pattern, but proclined upper and lower anteriors. This is the class 2 D1. You can see all the features of the class 2 D1. Class 3 concave profile, reverse overjet, retroclined lower anterior, class 3 molar relation. All these features you can see in this case. What are the drawbacks of the angles classification? The main drawbacks we considered only in the anterior, posterior, or sagittal plane. We considered first permanent molar to be a fixed point. But in the case of missing permanent molar, this classification is not applicable. And we cannot classify the deciduous dentition. He does not differentiate between skeletal and dental malocclusion. He doesn't highlight about the etiology of the malocclusions. And the individual, that is intra-arch malocclusion or individual tooth malpositions, have not been considered in the angles classification. These are the various drawbacks of the angles classification. What are the importance of the first permanent molars? The main importance of the first permanent molar is the first tooth erupt in the oral cavity. So high chance of getting it to be a decade. So the first permanent molar is considered as a key of occlusion by angle. This is the basis of the angles classification. It takes up the maximum load during occlusion, and first permanent molar is considered as the main anchorage unit during orthodontic treatment. The loss of this tooth causes drifting of other tooth into this space, and there is a key ridge, which is the mesiobuccal cusp of the first permanent molar is in the line with the mesiobuccal root and transmit the force to the zygomatic buttress. So key ridge is present at the in the line of the mesobuccal cusp or mesobuccal root of the first permanent molar, which helps to transmit the force to the zygomatic buttress. So maximum masticatory load is taken up by the maxillary first permanent molar and is transmitting to the key ridge area. So by this, I am going to wind up my class. These are the main basic things. This is the first part of the classification of malocclusion. The next part I will be covering about the various modifications of the angles classifications. So we'll see in the next class. Bye. Thank you.